And our pleasure to have Dr. Ranjan Das from Arvind Eye Hospital, Madurai. Dr. Das is going to discuss on keratoplasty in difficult situation, a avid academician with an extensive publication track record. Over to you, Dr. Das, for your talk.
Good morning, one and all. And at the outset, I would like to thank the AIOS and the Dr. Somsila for giving me this opportunity. So today's topic given to me is the tips and tricks for keratoplasty in difficult situation. And actually, all of us will love to do the advanced surgeries like lamellar, whether anterior or posterior. But still, I feel the keratoplasty in difficult situation remains a challenge for all of us, irrespective of our experience, and it takes some guts to finish the surgery in a proper way. Next. So the common difficult situation can be keratoplasty in glaucomatous eye, and again then keratoplasty, we repeat keratoplasty with IOL removal and lens removal and IOL implantation. Then periodic keratoplasties, then penetrating keratoplasty in a complex herpes or corneal opacities, and then large diameter corneal grafts like keratoglobus or a rupture pellucid marginal degeneration, and keratoplasty in aphakias. So all these difficult situations will have a common difficult problem. So common difficult problem like inadequate achalasia, positive vitreous pressure, lens expulsion, bleeding from the vascularized cornea, definition technique difficulties, definition in perforated corneas, and endothelial loss during the procedure, and a poor wound apposition, flat graft or IOL power calculation in scarred corneas, and large graft management. So coming to one by one situation, to have this to go rid of this inadequate achalasia or positive vitreous pressure or lens expulsion during the surgery, we should have good anesthesia with a perivalvular block and hyaluronidase with good facial massage and after the block, and control of systemic infection like hypertension and asthma, and secondary glaucoma should be controlled with IV mannitol. Patient head of position, proper speculum selection, canthectomy, and use of flaring rig wherever needed, and vitreous tap whenever needed when the glove is hard, and the use of price graft over host technique will be necessary to tide over these situations. Bleeding from vascularized corneas can be pre-op handled by using brimonidine or phenylephrine drops, or controlling the ocular inflammations. Wet field culture can be done, and subconjunctival or perilimbar Avastins are given by some surgeons during or after or before surgery. Definition techniques difficulties can be is a big challenge during the surgery. We need to get a good optical center marking, and for that we should first remove the bullous keratopathy from the cornea, and then use the radial marker. Use of vacuum trephine is advisable in all these cases. Microscope illumination should be perpendicular to the iris plane so as to have a good centration. Glove, if at all it is decentered, can be centered with forceps, and after trephination of 3/4 depth, you should have a slow decompression. So trephination in a perforated cornea is more important. So we should only go for a facial block and then mark the cornea and go for the manual excision. And the endothelial loss can be tackled with proper tissue handling during surgery and use of viscoelastics. So poor wound apposition and flat graft can be managed by oversizing the graft by 0.5 to 0.75 size, and reassessment of the graft during intraop, and then having good suture bite and with equidistant length. So IOL power in a scarred cornea is a challenge, so we will prefer to have a IOL power calculation only after taking axial length for A scan or B scan, and then taking the keratometry from other normal eye, or you can use the other eye normal eye keratometry and axial length and put the IOL power to get the approximate power. Large graft usually is needed for keratoglobus and advanced keratoconus or post-vitrectomy eyes. Use of flaring a ring and use of 1 millimeter larger graft along with more than 16 suture will tackle this situation. Overall, we have to give systemic immunosuppressive for all these cases because of high risk graft. So the price over graft technique, which I'm going to demonstrate today, will tide over the lot of tension during surgery, how much experience you have got. So this is a technique which is described by Price, in which he has refined the host cornea and sutured in the same way first, and then after cutting the 3 to 4 o'clock host cornea, he sutured back the whole cornea, and then with the non-cardinal sutures being anchoring sutures, he is used that normal graft over it. And in between he used the endothelial cushion. So I'll show you the modification which I have done in this video. And this is a case which was a bilateral macular dystrophy, corneal dystrophy, and left eye presented to us with a failed graft with secondary glaucoma. And this is how we managed to do the case. You can see after the proper block, so I have modified this technique to take a anterior 80%, 70% of stroma debulking. After the debulking, reassessment of the graft size is done, and then after slow entry, I have cut the 3 to 4 clock hours of cornea, residual cornea, and I have put the suturing in the non-cardinal side. You can see the severe positive pressure and iris popping out. So after putting this non-cardinal sutures, and then you put a viscoat over the cornea, and then you start using the 4 suturing. You can put a loose sutures or a little bit adjustable sutures. Once these 4 sutures are intact, then you cut all the basic non-cardinal sutures from all sides, and then remove the residual stromal tissue. And then you can tighten the 4 sutures, usually adjustable sutures, and then you finish the surgery. So this is the sequence of surgery for that case. And next is the another case which has got the fungal keratitis, failed TPK, and it came with the desmontocele. We have also done the same sequence of surgery, but here we have done a cataract surgery along with it. So you can see the sutures are still intact. So I have cut the few sutures here, 2 sutures, anchoring sutures, and remove the lens, cataractous lens, then put the IOL and put the suture back with the residual stroma, and then completed the surgery with the graft over technique. So take homes is in the preoperative workup is needed to get a good anesthesia. In spite of good maintenance of the IOP, you still may have to be doing very fast suturing, and overall the graft sizing has to be a little bit more, about 0.5 to 0.75 millimeter, and then use of liberal viscoelastics to take over the endothelial or tide over the endothelial damage, which is expected a little bit more here. So thank you for your kind attentions. My acknowledgement to Dr. Vishnu and Naveen and on my audiovisual system for helping me out. So thank you so much, Arvind, for listening.
Thank you.
And thank you all
Dr.
the panelists.
Das. It was a pleasure hearing you and having you on this forum. I am going